Hello, everyone, and welcome to Recovery Planning in Behavioral Health, the MHTTC webcast. We'll get started, and Janis will begin.
Great. Thanks very much, Ingrid, and welcome to everyone on the line with us today. My name is Janis Tondora. I'll introduce myself in a bit here along with my co-presenter, Dan Wartenberg. But first, I just wanted to offer a little bit of context and background to today's webinar. So this is actually a webinar of the Mental Health Technology Transfer Center network, and in particular, today's webinar is sponsored by Region 1, which is the New England region. And for those of you that aren't familiar with MHTTC, really the aim, the mission of MHTTC is to talk about using evidence-based means to disseminate evidence-based practices to promote resilience and recovery of people who are living with or at risk of mental health conditions. And there's a particular focus in this New England MHTTC on the delivery of recovery-oriented practices, and also the development of recovery-oriented systems of care. So our topic for today, recovery planning in behavioral health, is considered to be one of those fundamental practices in a recovery-oriented system. So this webinar series is actually one of the earlier ones delivered within the MHTTC offerings. And for those of you, again, that may not be aware, this is part 2 of what was a 2-part webinar. Dan and I were with a large group of folks a few weeks ago, and in that initial webinar, we provided more of an introduction and overview of the person-centered recovery planning model, and I just want to point out for people on the line, if this is the first time that you're joining us today, that webinar number 1 is archived and recorded, and it's housed on the MHTTC website, which I will give you in just a minute here. So just a quick bit of housekeeping to make sure folks are aware of. If you're having difficulty with your audio, it really does help with the quality. Please mute your speakers on your computer if you're calling in. Otherwise, you often get an echo. The webinar is actually being recorded for posting, and want to make sure folks are aware of that. They're typically posted within a couple of days, actually, on the MHTT site. And Dan and I want to call attention to the bottom left-hand corner of your screen. There's a chat and questions box. We have built in some different places within the slides where we're going to do some interactive polls and things like that. But in addition to that, we really encourage you to use that chat and questions box. While I'm presenting in the beginning, Dan's going to try to keep an eye on that for me, and I will do the same for him when he takes over about midway through. We may pause and answer some of those questions midstream, but we're also going to try to leave about 20 minutes at the end for additional Q&A, which we plan to really kind of pull from that chat box. So again, please don't forget that that's there, and feel free to use it. If you have questions that pop up after the webinar, you see here on the screen is the email address of the New England MHTTC group, and they would be happy to direct those and to forward those to Dan and I. So here is not only the email address, but also the website. Again, that is where you can find a bunch of information about what is being offered through MHTTC, as well as the first archived webinar that Dan and I did a couple of weeks ago. I do also want to mention for any representatives who are on the line from our New England region of the MHTTC, in addition to this webinar series, person-centered recovery planning is going to be a topic around which some more intensive training and technical assistance is going to be offered within the context of a much more extensive learning collaborative model. And there are going to be opportunities for folks from the 6 participating states to actually apply to be a part of that learning collaborative and to get some more intensive training and TA on this topic. So Dan and I are very excited to be involved in that, and I hope that many of you will be as well. So additional information and detail on that learning collaborative application will be forthcoming and sent out from the MHTTC group. So again, just please check out the MHTCC website. In addition to this webinar, there are very frequent topics that are addressed both through webinars and different platforms and whatnot. So you see some of our upcoming events happening both at the end of this month, but going on over into July there, everything from trauma-informed care to really taking a closer look at motivational interviewing, et cetera. So now I think, Ingrid, can we switch on over to the primary presentation? Just a second, folks. We're, here we go, pulling up our primary slides here. I think we're going to actually start with introductions. So this would probably be a good time. Before I dive into the content, Dan, do you want to say a few words of hello?
Sure. Hi, everybody. My name's Dan Wartenberg. I'm a psychologist by training, have been in this field near 40 years now, held a number of different roles, anything from QI to running an inpatient unit to running outpatient services, was CEO of a large state-operated mental health center, and I'm currently the Chief Clinical Officer up in Newport, Rhode Island. I've been involved in person-centered care and implementing person-centered approaches probably for about the last 15 years. Have worked very closely with Janis and the group from Yale during that time, and have had a number of experiences about what works and what doesn't work when you're actually trying to roll this practice out. Last week we spoke more in general. This week I'm going to focus more on my part on implications for electronic health records, which are a part of our lives, for better or for worse now, and how that dovetails or doesn't with a person-centered approach. So looking forward to talking, I guess, is it with you or at you, but talking.
Great. Thanks, Dan. I'm Janis Tondora, and I am an associate professor at a Department of Psychiatry program called the Yale Program for Recovery and Community Health. While we do a lot of research, certainly within the context of that program, I would say that I'm very much a kind of translational field-based person on our team, meaning that I've spent the vast majority of my career when we're talking about topics and doing research on things like recovery and strength-based and person-centered. I'm really the individual that tries to think about how does that actually translate into practice guidelines that people who are in the field can actually implement on a day-to-day basis to enhance the quality of care and the types of partnerships they have with folks. We do that work in a wide range of areas, but the thing that I am most passionate about is the co-creation of a collaborative recovery plan as a way to shape the work that people are doing together out there. And we've done a lot of that work here with our public sector behavioral health department, the Connecticut Department of Mental Health and Addiction Services, which has been a decades-long supporter of this kind of work. But also I've had the opportunity increasingly in the last decade or so to do this work in many other states around the country. And I say that in part because that's really been a tremendous opportunity for me to learn, and to learn in ways that I think are directly relevant to our conversation today. Partly because in the greater scheme of things, let me show you what we're going to be taking a closer look at. We did more of an introductory overview the last time that we were together, where we talked about an overarching model of person-centered recovery planning, that it really has to have that foundation in the 4 Ps, if you will. So it has to have a foundation in the philosophy of recovery. That philosophy informs perhaps a different type of a process and different types of roles and relationships and what planning meetings actually look like. And then from those planning meetings evolves perhaps a different type of enhanced recovery plan, be it in paper or electronic. And that all being really serving the broader purpose of not just focusing on the more narrow clinical outcomes, but really talking about kind of that life in the community that a person desires. So what we're really going to be doing the much deeper dives in this afternoon is really taking a closer look at the documentation. And that's really where I have had an opportunity to learn from my travels around the country, because in interfacing with probably hundreds of agencies at this point and dozens of state behavioral health authorities and Medicaid offices, we are very much aware that there is this tension around how do you write a plan that both honors the person and it satisfies the chart. People often feel like they get sort of squeezed between this rock and a hard place, where on the one hand, they experience a tremendous amount of pressure around complex regulations and required paperwork and maintaining their golden thread of medical necessity so that they're meeting compliance expectations and so forth. But at the same time, within a recovery-oriented system of care, there's emerging consensus and expectations around the fact that we need to be planning in a way that's collaborative, it's strengths-based, it's person-centered, and folks are on the same page. There's transparency in the information that is being shared. So I am really often presented with a question about how these seemingly competing tensions come together in the recovery plan, and are they like oil man and water girl up here, and is their relationship doomed? Is it a happily ever after, or are we somewhere in the middle? There's a peaceful coexistence. And I really want to send the message early in the webinar that I am a firm believer in the fact that we can honor our various quality expectations, and we can do that in the context of one well-written, co-created plan that you're doing in partnership with the folks that you serve. There's nothing about the method of documentation that we're going to walk you through today that should compromise the necessary clinical rigor, the documentation expectations that we realize you need to have in place, whether that's for a joint commission or CARF accreditation or Medicaid auditing or state behavioral health oversight. In fact, I would say that overall, it has very typically been my experience that when we're doing this kind of recovery planning training within systems, almost inevitably. In fact, I was just in a state hospital in the state of Massachusetts yesterday, working with a fabulous group of people who have been, at work at this for a long time. And in the context of their Joint Commission review and sharing some of the person-centered plans they had created, the Joint Commission was clearly sending the message this is exactly the type of individualized quality in the documentation that we're looking for. So our hope is that this is going to put you on firmer ground in your documentation and not really open you up to risk. So we're going to talk about what that looks like. I do want to let you all know, don't worry about the tiny font on this screen. I just wanted you to be aware that we have gotten permission to share with you a couple of really practical tools that really are quality indicators checklist, if you will. So if you're running a person-centered recovery planning meeting, what does that look like in practice? And we've created a similar tool. Some people think of it as sort of a chart review tool, a quality audit tool. What does a good person-centered plan look like? So we're going to talk about that on today's webinar. But when we both post the materials, we will post these tip sheets along with the slides. So those will be coming your way, just so that you know. So I want to start just by saying, yes, we're going to focus primarily on the goals and the objectives and the interventions, but your plan is really only as good as the assessment that it's based on. And the assessment, frankly, is only as good as the relationship that it's based on. But as far as assessment goes, while we can't get into detail, I do want to point out that I think that it's enhanced in a couple of really key ways. So we think obviously a lot more about the different strengths and interests that a person brings to their recovery process. We want to attend to different cultural preferences and how that might result in some treatment implications and preferences. And also thinking about stage of readiness. Where is someone at in their thinking process and in their recovery? We do a lot of writing recovery plans around this country as if everyone is at an action stage of change. And in some cases, we really need to sort of take a step back, and we need to maybe be more modest, and we need to really, truly meet the person where they're at. And that has implications actually in the documentation, how you write goals and objectives and so forth. And lastly, what I would say is that, before you can write a good quality recovery plan, that has to have a foundation in a more holistic understanding of the person that's typically reflected in an integrated summary, right? So you have your comprehensive assessment, you have your recovery plan, but in between, typically we're writing some kind of a summary about how we understand the person's story. But unfortunately, that story often gets reduced just to a repetition of the data, and we really have to get to a deeper level of understanding and kind of move past just the what, we say, kind of the facts, and really dig a bit deeper and think about the why. Like, how do we understand what's going on with the person, what might be perpetuating some of the difficulties, because that has a really direct impact on what the documentation ultimately looks like. So I'll give you some examples of that as we kind of move through. I think the biggest one that often stands out for me is that I see a lot of reference to people not using medications across the assessments. And it'll say 15 times in the assessment, medication noncompliance, medication noncompliance. And then when I get to that summary, that integrated summary, oftentimes the summary says the person has a long history of medication noncompliance. When in reality, that statement doesn't give you much value added in terms of informing the plan. You already told us that in the assessment. The question you really need to be thinking of when you're writing an integrated summary prior to your plan, you have to be asking the question and talking to the person about, why is it that you're making a choice not to use medications? How do you understand that? Because the answer to that question is going to take the plan in many, many different directions and have direct implications for your documentation. So if someone's in a position where they're choosing between the copay on their meds and putting food on the table for their kiddos, then they may need some kind of an intervention around getting connected to financial entitlements. If they have a cultural or a faith-based objection to taking medications, then perhaps we need to reach out and involve someone from their faith community or their cultural community. Maybe the medications just aren't working for them and they're just not effective, in which case we need to pull in physicians and prescribers and really do some brainstorming around that. So just, again, keep in mind there's a lot of things that come before a well-written recovery plan, and just keep in mind in particular the quality of your assessments and your formulations. So I briefly gave you a sneak peek of this on our first webinar when I walked you through the Mr. Gonzalez example. This is a big picture view of the person-centered recovery planning elements. You see our scale kind of as a watermark there in the background, just again highlighting the fact that there is a balance here in terms of what we're focusing on. Being person-centered and goal-directed and strength-based doesn't mean that we're going to be neglecting the barriers or the problems that are interfering with a person's life and their recovery. However, how we look at those barriers and how we treat them in the documentation does perhaps look very different than traditional methods of documentation. So on the left, you see what we historically do. We historically derive the treatment plan content directly from the problem list. So we might have a person who's got a number of problems, and we might say problem number one is assaultive behavior. And what's your goal for your assaultive behavior? Problem number two is poor hygiene or self-care. And so what's your goal for your poor hygiene and your self-care? So you see that's a very kind of deficit-driven approach in the flow of the documentation. In contrast, on the right, you see what we're really talking about is the plan gets integrated at the level of the goal that is most important to the person. And then we're going to address the barriers insofar as they're getting in the way of that. So in this example, perhaps the person says, I want to get my job back so I can provide for my kids. But perhaps they've had some difficulties with impulse control, and that's led to conflicts with coworkers. So they've been terminated from their last few jobs. Perhaps they are struggling with their self-care and their personal grooming routine. And if they want to put their best foot forward at a job interview, they're going to potentially need some attention in the plan around that. Or maybe they're struggling with substance use, and that led to absenteeism in the past. So what you can hopefully begin to see here early on in my remarks is that it's not that the barriers are getting swept out of the picture. They're going to continue to get responsible attention in the plan. We're just going to be framing them insofar as they're really getting in the way of that valued recovery goal. So what are those valued recovery goals? What do folks want? People want the same thing out of life as everyone else, whether they live with a behavioral health diagnosis or not, right? They want spiritual connections, maybe to get back to church. They want independence. They want to control their own money. They want to control their lives. They want meaningful, satisfying relationships. Maybe they want to see their grandkids, or maybe they want a partner in life. They want to be part of the life of the community in a meaningful way. And not just sort of the territory of traditional treatment plans. We've made a lot of progress in this area, but I do have to say that in many of the plan reviews that I'm doing in places around the country, I still see some of the most common goals are maintain psychiatric stability and medication compliance, as the goal statements on the plan. It's not to say that using meds as a tool in your recovery, that achieving some sort of management around symptoms isn't an important part of the plan, because certainly for many people it can be, but those are not a person's goals in life. To be med compliant is not a person's goal in life. We're really trying to focus on that bigger prize there. So a couple words just about how we want to think about and how we coach people to write them. Typically the goals are longer term. They're kind of more broadly stated. We're focusing on the life changes as a result of services, and we want them as much as possible to be in a person's own words, as quotes. Not everyone is going to be able to do that on their own. We'll talk about that in a minute. And some people may have difficulty stating them in positive terms. So, for example, we often say you want your goals to be things that a person is moving toward and not just what they're trying to get rid of. So if a person were to say to you, I just want to be less depressed, and they're very focused more on the resolution of the symptom, that's where talented practitioners use their skills and say, so if you weren't so depressed, how would your life look different? How would you be spending your time, right? So somebody may say, well, I might get my job back. Maybe I'd get out of bed in the morning and go read at my kid's kindergarten class. It's that kind of skill in the goal setting where you use your skills as a practitioner or the supporter to try to help people be thinking in that forward-thinking way. And of course, we do hear a lot of goal statements that are consistent with this desire to have control over one's own life and their recovery, but recognizing, of course, that that is something that's influenced by personal worldview, by cultural values, and that's not always consistent across cultures or within cultures. Some people have a much more collective decision-making process, or they might defer self-interest to the group or the family, et cetera. So these questions oftentimes come up in goal setting in the field. People can have challenges with goal setting for a lot of reasons. Some people just may not be used to focusing on this because their plan historically may not have focused on it. It may have focused more on managing the problems. I know I certainly work with folks in trying to kind of engage them around the goal setting, and folks will say to me, I'm going to take my meds, I'm going to come see you one time a week, and if I have a thought of hurting myself, I'll go straight to the emergency room, and can we sign this plan and be done with it? Go get a cup of coffee. Because people have a very narrow vision of what the plan can be about. So this is a partnership. And if a person's having a hard time articulating some of these things on their own, I just want to say to you all on the line, it's perfectly okay for you all to suggest something to get the ball rolling. Practitioners often say to me, well, I don't want to put words in the person's mouth. But if the person is struggling, you may know from observation, from referral information, from a family member or collateral, if you have permission to speak to them, what would a better life look like for this person? And it's perfectly okay to offer suggestions there. And I sometimes say, just be careful of just the whole goal-setting language around talking with people about setting goals. It can be pretty intimidating at times. You can have a lot more luck just kind of backing up and sort of saying, what does an ideal day look like for you? What would you be doing, and who would you be spending your time with? Again, just to sort of put the person in a different mental space where it's easier for them to kind of envision a different future for themselves. So just some information here about the importance of really thinking broadly about strengths and how we incorporate strengths into the plan. That strength field in your plan, whether it's in paper or electronic health record, it really should never say none. Sometimes people may have a hard time identifying them on their own. But again, feel free to make observations. What have you noticed in the work together, just so that we can be focusing a bit more on what's strong and not only what's wrong or what feels like it's not going right in the person's life. I would say with the key point I would want to make on strengths is that I think practitioners overall are doing a really excellent job increasingly of identifying strengths within the context of their comprehensive assessments. However, having done that and having worked hard at it and invested the time in it, for me the biggest tragedy is that oftentimes all of that great information does not get actively incorporated into the recovery plan in a meaningful way here. So I've just given you a couple of different examples of what that might look like. I think the active sort of tapping into the strengths, you can really use those sometimes to give a person something to move toward in their life, as opposed to just focusing on things that they're trying to sort of leave behind, if you will. I remember doing some work in some residential settings in a group home with a older gentleman, and the team had been working for a long time to support him in moving into an apartment in the community on his own. And every time they got close to that transition point, he would get extremely anxious. He was very ambivalent about leaving. He had been there for a very long time. And he would typically, when he got close to the transition point, he would start to really struggle with symptoms. He would get highly anxious. Sometimes he would end up back in the hospital. And the team did a lot of brainstorming around this. But the thing that really ultimately got him moving forward, we had a research project, and a peer specialist was doing a strength-based interview with him, and he had identified that he had been a competitive swimmer when he was much, much younger, and actually highly competitive, actually had been, I think, either at Olympic trials or had actually competed, but incredibly accomplished swimmer. And so from that one fact that emerged in the strength-based interview, the team at the group home started working with him. One of the things they built into his plan is that they got him volunteering at a local community center pool, doing some teaching to teach some of the kids in the city how to swim at the community center pool. And so they worked this into his plan, but then ultimately what had happened, the community center pool was on the other side of town, very close to the apartment that they had been trying to move him into for a very long time, and very far away from the group home that he had been having a hard time leaving. So it wasn't something magic, and it didn't happen overnight, but it was a huge part of what the team was able to draw upon with him to help him successfully make that transition. So the importance of strengths, we can't emphasize that enough, but the importance of actually using them actively. So all that to say, the barriers are also not neglected, as I've mentioned previously. So really thinking about what's getting in the way of helping the person achieve some of these goals. Why can't they do it tomorrow? Why are they struggling to do it on their own? You want to consider a number of things, some of which may have to do with a person's experience of their behavioral health condition, but also some of the things that are just associated, frankly, with the experience of poverty, especially if someone's being served in the public sector system and they are dealing with the psychosocial stressors around that. But a key thing is making sure, and we're barriers, that we really are being explicit and descriptive in our detail around those challenges and needs as they relate to their experience of a mental health or an addictions issue. There's a lot of confusion around this in the field, and sometimes people, for example, will write down in a barriers field on the plan, a person has poor budgeting skills, okay? And while that may be something they struggle with, half of America has poor budgeting skills, right? And they can't all come to your outpatient community mental health center. So we have to be clearly articulating what is it about their experience. Are they experiencing some disorganization in their thinking or their concentration, so they have a hard time with budgeting? Are they so depressed and overwhelmed that they can't bring themselves to actually take the bills out and pay them so they keep getting evicted? What is it exactly as a result of their experience that's getting in the way of the goal that's important to them? This is important for two reasons. We often talk about this because it's an important part of weaving that golden thread of medical necessity. But at the same time, I'm just a firm believer that level of descriptive detail is critical also just in writing a good quality plan of care, because together with a person, we have to get clear on what is getting in the way and how, so we can then offer appropriately tailored behavioral health and other types of interventions. So let's take a closer look at what some of that descriptive language might look like. We would just caution people to be really careful about defaulting to labels. Sometimes we default to shortcuts when we're doing our documentation and our planning. It is okay to be clear and explicit about the fact that a person may be having significant difficulty in their experience of symptoms with functional impairments. But as you can see from some of the examples up here, you really want to be descriptive about what that looks like for that particular individual. So, not labeling, Harry by his diagnosis of being quote unquote schizophrenic, talking about the fact that he's hearing a lot of voices. We're talking today in our session about what the voices are saying, how that makes him feel, and how it's been a problem for him in concentrating at work. So again, that's going to help you not just with your medical necessity, but also in writing a quality individualized plan of action around those issues. But I also want to point out that the descriptive detail, when you write your barriers, it has another function. In my mind, I think it's really important because it's an opportunity to connect back to that recovery goal that's the most important to the individual, and likely their motivation for staying engaged in care to move forward in their recovery. So if a person, for example, is really focused on wanting to get that apartment of their own, instead of just globally saying anger issues, really talking about the difficulty they've had with conflicts or maybe outbursts with neighbors, which have created problems in their own apartment. And not just talking about depression, but they had a hard time taking care of some of their basic household tasks. And not just globally speaking about addiction, but maybe the substance use has led to lots of folks in and out of their apartment, unwanted activities. So maybe the cops are involved a lot and they've historically gotten addicted. So the reason we say it's important to connect the dots is we're constantly engaging with folks about we're not sort of forcing these things in the plan because we're making a judgment that they're important for you, but you're saying that what's important to you is that you really want that apartment of your own, and let's talk about what's been getting in the way of that. So again, just be thinking about the descriptive level of detail. So a couple of words about objectives here. Again, there's sometimes confusion about what they are conceptually. They're the most technical part of the plan to write. These should be concrete changes in functioning, changes in behavior, changes in status that break that kind of longer-term goal down to those more manageable steps. They're really the proof that the person is getting closer to that long-term recovery goal. And then as people are able to kind of check them off their list, they serve a critical function because they do send a hopeful message to folks that, together you really believe things they can and they will be different for the better and in a pretty short period of time, right? So this is a mnemonic that's probably pretty familiar to many of you on the line with us today. This is the SMART strategy of writing your short-term objectives. There's actually a little bit of debate in the field about what each of these letters stand for. We often talk about, again, just the simple, the specific, the straightforward. You want them to be concrete enough and measurable. You want to have them at just for the right level. You want them to be ambitious enough that they feel meaningful, but not so ambitious that the person isn't going to have a likelihood of success. And you want them to be relevant. You want them to be addressing a target area that's interfering with a life goal. And last but not least, you want to think about a time frame or a target date. So the SMART memory mnemonic may be helpful for some of you, but really at the end of the day, I often tell folks, just read the objective out loud and just ask yourself at the end of the time frame, are you going to really definitively be able to say, was the objective achieved or was it not, without arguing amongst each other on the team? And if there's debate around it, typically it was missing the mark on the measurability criteria. So here's a quick formula that we often encourage folks to use when they're getting comfortable with required elements. So within a certain amount of time, the individual is going to have improvement in this particular barrier as evidenced by what concrete change in functioning, change in behavior, or change in status that's meaningful for the person. So, for example, you may have John who is working on his recovery plan of, maintaining his job or getting his job back in the community. Maybe part of what's been interfering with that is his panic disorder, and he's been unable to be consistent in his attendance because he's having difficulty riding the subway. So maybe within 30 days, he's going to have improvement in his management of his panic symptoms as evidenced by successfully riding the subway to work without exiting the train before his stop. Again, this being based on real experience where these were issues of folks kind of interfering with their goals. Another word about objectives, very critical. I think this is one of the biggest slippery slopes I often see in the documentation and where things go awry. Sometimes they do a great job with the goal and the strengths and the barriers. What sometimes can happen is regardless of what that goal statement is, I drop down to the objectives, and the objectives are all about service participation, right? So Wanda's going to attend DBT, Wanda's going to meet with a psychiatrist, Wanda's going to participate in case management 2 times a week. Case management, psychiatry, DBT, those things are an important part of the plan, but they are interventions, okay? And attending those things does not in and of itself guarantee that Wanda's going to make progress. So this is an example here of someone who was living with a trauma disorder and was engaging in some self-injurious behavior and some cutting as a way of sort of managing emotional pain. And that had led to a disruption in her marriage and a separation, and she was working on a goal in her plan of trying to reunite with her husband because they had become estranged. So the objective there for Wanda is not to attend dialectical behavior therapy, DBT, because she can attend and attend religiously for the next 5 years and not necessarily change the behavior in a meaningful, positive way. So when you're writing your objectives, be careful. You don't want to default to service participation. Instead, you want to focus on something like Wanda using new mindfulness strategies to reduce instances of self-injury to no more than 1 per week for 2 consecutive weeks. And obviously that can be modified based on your assessment and your conversations with Wanda about where she's starting and where she wants to go. And then last but not least, interventions, services, methods, action steps. These are a critical part of the recovery plan. We want to be thinking about offering, where available and where preferred by the person, a range of evidence-based practices, taking into consideration a person's choice and preference. This is essential not only in describing your medical necessity, because what you're doing there is you're describing in that intervention how the services that you are providing are helping the individual overcome their barrier en route to that short-term objective. And you really do want them to be specific. So when you read your interventions, we sometimes say, you want your plan to make sense from the top to the bottom, but also you want to read it from the bottom to the top. So before you put an intervention into a plan, you want to look above it, and you really want to make sure that it's linked in a logical way to the objective that you've included above it. Sometimes we get a lot of things put into that intervention section that while they may be an important part of the plan, they don't necessarily fit, if you will, in that particular area. So don't forget with those professional interventions, you want to be real clear about who is providing the service, what exactly it is that they're providing, not just kind of meeting with, but what's the title of the group. Maybe it's a health and wellness group. When that service is happening, what's the schedule? Is it, 1 time a week for 3 months? Is it once every 3 months, et cetera? And then really important, why? What's the intended individualized purpose and intent of that service as it relates to that individual, how they're overcoming their barriers to achieve that short-term objective. And finally, we would say that a critical part of quality documentation and recovery planning is not to forget your self-directed and natural support actions. So traditional treatment plans are dominated by everything that professionals do. So the doctor does this, and the therapist does that, and the voc specialist does this. You're all still really important in the plan and in the equation, but we would say it's critical to build that sense of kind of agency and involvement by identifying some kind of self-directed actions that the person feels good about, that they can own, that they can take responsibility for. I'm giving you a couple of examples up here. And similarly, if they elect to have natural supporters involved in their planning process, really thinking about in what ways might someone's sister or their friend or someone from their faith community, how is it that they might contribute to the plan? You know, maybe someone, priest is going to help to arrange rides so they can get to and from Sunday services because that's an important part of their recovery. So let me end with a quick poll here before I turn it over to Dan. I want to tell you about quick snapshot, someone we called Jerry. Jerry was living with a diagnosis of disorganized schizophrenia, and he had spent many years off and on in the state hospital. When he was in the community, he had been living in a 24/7 residential group home. He would often say that he was incredibly lonely. He had some interests. He really did love music. He would, in the past, go to downtown jazz festivals and try to meet people, but was saying at the time that this plan was written that he really felt like a zombie. He wasn't getting out of the house at all other than to come to the center for therapy. He didn't know if it was due to his meds or something else. He talked a lot about how he really wanted a girlfriend, but he admitted he was kind of terrified to get out in the community and meet a woman, a girlfriend. He said it's been 10 years since he had dated anybody, didn't know where to start. He was unable to take the bus, afraid to go anywhere alone because he would tend to get confused, and he also would often feel threatened and fear that others might try to hurt him. So based on that quick snapshot, if we can open up the poll, Ingrid, and I'd like you all just to weigh in here on that quick snapshot of Jerry. What do you imagine might be a goal for his person-centered recovery plan? Go ahead and just take a minute and pick from one of the 5 options up there. And then I'll just give you some feedback. Okay, so as these are coming in, let me see. So I'm seeing it's looking like, oh, we have a neck and neck. We're neck and neck between number 1 and number 3. Okay, so let me tell you a little bit. So number 1, you hear Jerry saying that. I mean, that is a quote that he's saying. But remember the piece of feedback I had given around goal setting. As much as you can, you want your goal statements to be not about what you're trying to get rid of, but what you're trying to move towards. So if you were to ask Jerry, if you didn't feel like such a zombie all the time, how do you think your life would be different? Okay? And in this case, Jerry would tell you pretty darn clearly and pretty consistently, he would say he would get out there in the community and he would meet someone. He would have girlfriends after not having had one for a long time, okay? So that's just in terms of number 1. Keep that in mind. Number 2, we would say, is a bit too focused on that narrow management of the clinical symptoms. And again, with the goal statement, we want to be thinking about that broader life in the community and what's important to him. Whereas number 4, Jerry attending the social skills group. The social skills group is a service. If he attends the social skills group, what is he going to get out of it, and how do you hope his life's going to be better? Each of these things kind of goes back to what Jerry was saying consistently. So we would say that the goal on the plan there, that the best one to go with in this case really was number 3, I want a girlfriend, okay? Number 5, he might also just say, but it's a little bit too vague. So we want to say, well, what would make you happy, Jerry? And he would pretty much tell you, a date on a Friday night. So number 3 is a little bit more specific. So let me show you what that might look like. People get very anxious, and rightfully so. We are not Match.com. We are not in the business, and we do not get paid to help a person get a girlfriend. But what I want to leave you with is, this idea of remembering we don't get paid for a person's goals at all. we get paid for clearly documented, individualized professional services that help a person overcome the clearly documented mental health-related barriers that are getting in the way of those goals that are important to them. So we would say that you can do this in the context of the plan. So just to share with you a quick snapshot here, he would say, I want a girlfriend, someone to share my life with. He had a lot of strengths to draw upon. He was very motivated. He had an involved and supportive brother. He knew what he liked to do. He loved music. He loved Chinese restaurants. He's a very funny guy, very well-liked. But at the same time, he had a number of significant barriers and issues related to his experience of his mental health condition that got in the way. So you can see these documented up here. He had very intrusive thoughts. He would often feel threatened when he was out in the community. He maybe had some negative symptoms of schizophrenia that led to some of that lack of initiative and isolating. He also could get really easily confused and disorganized. He had a history of getting on the bus and getting off the wrong stop and getting very confused. And when approached by someone trying to help, he would often tell them the only place he knew where to take him to get help is he would often tell them to take him to the hospital. So it gives you a sense of some of the things he was struggling with. So in this case, we started with one quick objective, targeting some of this discomfort that he had around others, that sort of sense of feeling threatened. So Jerry's comfort around others will improve as evidenced by his participation in a minimum of one preferred social activity outside that group home each week for the next 90 days. So we're just starting by trying to kind of get him going and get him out of the house a bit more and feeling comfortable enough to do that. And as you can see here with this final slide, he's going to need a range of different kinds of help to do that. Maybe he needs some cognitive behavioral therapy to cope with distressing symptoms in social situations, ongoing quality medication management to really evaluate the impact of the meds and take a look at that fatigue that he was experiencing. We had a peer specialist involved doing some rehabilitative type skills training and travel training so he could get on the bus and go out to those preferred activities. And last but not least, down the bottom, you see we got his brother, that supportive brother Jim, involved. So he didn't have to do all this stuff on his own. And Jerry himself wanted to take a close look at how he was feeling on his current medication regimen, really kind of tracking his side effects while the doctor worked on those. So this is not a complete plan for Jerry. Jerry also was in a pretty high intensity level of care. He had an objective, I think, around sort of personal self-care and grooming. He actually had just sort of smitten with someone who worked at a local Dunkin' Donuts. So, you know, the idea being, first we got to get him out of the house. Then if he actually gets down to the Dunkin' Donuts, he wants to put his best foot forward. So he had an objective around his improving his personal self-care and hygiene. He had some difficulties with communication, and he would tend to sort of perseverate and dominate conversations. So he had a communication skills objective where he was really practicing conversation starters so he could actually chat with the cashier at the Dunkin' Donuts when he got there. So hopefully by ending with that, it gives you a sense of optimism that you really can, I think, honor the person and satisfy the chart at the same time in one good quality recovery plan. That's really a key piece of kind of moving forward in partnership with folks. And that can be facilitated, or you can experience some challenges when trying to do that in your EHR. So I'm going to turn it over to Dan to kind of move us into the next part of our presentation here.
Thanks, Janis. Hi again, everybody. Ingrid, could you bring the next poll up, please? Okay. So I'm going to be talking about electronic health records, or EHRs, and if you all could just fill out the 2 questions below, give me a little sense of where you're starting. Okay. You guys keep filling it in, and I'm going to start. So, as I suspected, that the vast majority of you all and people in the field are now working with some kind of electronic health record. It is a fact of life, for better or worse, and in all their variations. And one of the things I want to see is to what degree does that record either feel like it's facilitating the practice of person-centered care, have no impact on it, or in some ways get in the way or make it harder to do. Okay, so it's looking actually like the results are, for the most part, people are feeling their EHR is actually helpful in helping them do their plans, with about, almost 60%. And then the others are somewhere between neutral and finding it problematic. So what I want to do is talk about what I think are the sort of the key principles that need to be built into the EHR, which is a lot of what Janis just talked about, but how that actually might look in an electronic format, and then show you some samples. I think I mentioned we are right in the middle of an electronic health record implementation right now, and have been designing one based on these principles. So I want to show you what we think that looks like, and what some of the pitfalls have been. Okay, let me go on. So this is, again, what we're trying to avoid, the old square peg and the round hole. For that person that has the skills, is motivated, wants to practice in a person-centered way, but finds it difficult to do so because what's in the tool that they have to document in doesn't match up. So how do you make it match up? Okay, here's our poll questions. So here's some things that I think we need to think about. So first and foremost, Janis just described a structure, okay? It's a hierarchical structure that builds on certain key principles. So probably the first and the foremost of that is what's driving the plan is a goal rather than the problem. So if you look at typical EHRs, there's a built hierarchy. So in a typical one, you will have a problem, and then you will have a goal to address that problem. Then you'll have your measurable objectives, and then the services that, sort of follow to that. There's a key flip in the hierarchy here, where the goal is driving the plan. And literally what that means is that the goal sits on top of the hierarchy, and everything that follows is attached to the goal. Okay? And again, that could be something as simple as what order it falls in, but usually there's actually a logical connection in the EHR that's underneath it that sort of connects it up to the driving principle, and you want that to be the goal. Okay. Excuse me. The second thing is, basically, a person-centered recovery plan is built on a dialogue. The more traditional problem-oriented plans are probably much more balanced towards the practitioner saying, look, here's what I think your problem is and what you want to do. And there's less space to have a conversation about that. And if it came to it, what do you do when you disagree? Okay? Again, in the old sort of typical model, you would just put it in the plan anyway because you need to put it in the plan and you feel it's important to be there. The odds of someone actually following through on that piece of the plan is probably not that high because they don't own the goal. So does a plan contain a place for this dialogue to take place and for it to be documented? Okay. As Janis mentioned, it's the idea of integrating the use of the strengths to overcome the barriers. So at this point, most of us have some place somewhere to list strengths. But if you embed it within the sort of goal structure and hierarchy, you're much more likely to do those tie-ins that Janis was describing about, oh, how do I use this strength to overcome the barrier to get what I want? Okay? The order the things are put in are very important. I remember when I was doing an early implementation, for some reason people felt the diagnosis had to be on the front page, and said it was in subregulation, which it was not. The plan had to include a diagnosis, but it didn't have to be the first thing that somebody saw or the first thing you're talking about. So in a goal-driven, person-centered plan, things like hopes and dreams, strengths, what your goals are, sort of leading with that helps to convey to the person that you're emphasizing and you feel that it's very important, okay? And this idea of going beyond documenting not just what you as the provider is doing, but the activities of the natural supporters and self-directed actions by the individual. Again, the more there's a place to put that in, the more likely people get used to thinking about it, talking about it, and using it in the plan. Okay. The other very major thing about electronic health records and about any treatment plan, recovery plan, is to what degree is it individualized. So for those of you who listened to the last survey, last webinar, we had a Joint Commission survey a couple weeks before, and we're cited about the plans being individualized enough. And it's nothing new that a plan should be individualized to the person, but one of the downfalls of the potential electronic health record is, in the tension to make things more efficient and guarantee compliance, you may lose that individualization. So how does that work? So again, why would you have a drop down? Well, for one thing, it's a lot faster for people. It's a lot easier. I don't have to think of what I have to write, and I can just click on one button and answer the question. The other piece of that is, if I want to make sure, for example, that somebody is putting in how frequently they're meeting for their therapy, the best way to manage that and control that is, again, to use it through a drop-down and make it a required field. So somebody's not going to get out of that record unless they have put in the things that you have to have, okay? And that serves those purposes beautifully, but if it goes too far, you lose your ability to individualize the plan. I have seen plans that are entirely built on drop-downs, and after reading it, I have no idea who the person is and what they're working on. What we recommend is some version, like a mixed version, of having drop-downs for things that you really need to have in there, and certain things that kind of lend themselves to them, but definitely having opportunities for open text where people can write in their own words and individualize the plan. And I'll show you a little later, about sort of how we operationalize that in our plan. The second piece is sort of a hard wiring of logic, okay? And this often falls in, so how do you guarantee the golden thread? So for example, in your assessment, if you have a problem that hits a certain level, it automatically populates into a domain of the treatment plan. And I've seen that done, and it surely assures that you're keeping the golden thread and connecting, but it's not personalized. You've taken the personalized, individualized aspect out of it, and I think, as Janis has mentioned, you tend to end up with 6, 7 very discrete problems versus a goal that is integrated and might include some of the problems you're trying to address all within a single goal and the context of something the person actually wants. Third piece of this are the auto-populating libraries. Wiley is probably the most wide-known of these. Again, it's tremendously convenient. I think they were developed for procedures that are very standardized, and rather than someone having to write out the same thing every time, you click on the button and it gives you a whole procedure. Okay? We feel pretty strongly these tend not to have a place in a person-centered plan because it's not so cookie cutter. And the things that we're doing, the procedures tend not to be so standardized that they're not individualized to the individual. And again, the last one is the domain-based piece, which is, again, and as I mentioned already, which is you get locked into a separate problem for every domain versus really, hearing what the person's goal is and sort of integrating up to that. Okay, and just one other thing for that. Again, these things get built in the EHR to prevent error, to make it easier in some ways. You can't program in critical thinking and patient-centered thinking. You can prompt for it. You can make it easy for people to do that. But in the end, you're still going to train and supervise so people still need to understand how to conduct the practice. Okay? Okay. So the other thing about EHR, so in the old days, however old they were, when you were on a paper system, something changes, it's relatively easy to just change it. You add a box on your form. You can generally just do that yourselves. That is not so simple anymore with the EHR. Depending on which one you have, there are certain things that you can probably change at your level, and then there are other things that you may have to go to your vendor to have them program in, which both from a time perspective and a cost perspective makes it much more difficult. So things tend to be more locked in the electronic health record than they were in old paper systems. So the other thing, and some of this may seem obvious, but you really need it to be easy to use. So in the development of the system we're looking at now, we got to one point where we think we really built in a lot of the principles of the plan, and they look really nice. So the elements were there, the goal was at the top, we had strengths, I'll show you in a minute. But the navigation was such a pain. You had to click in and out of like 7 screens to do it. You had to save like 14 times for each object that you were completing, that it was going to frustrate people. Okay, so that the design and usability of the system, again, can either greatly support or undermine the use of the plan. On the other hand, if it's designed properly and you can have all the things on the screen you need to see while you're doing the plan, it can make life a lot easier for yourselves. A second piece of this is how easy is it to get in and change your plan. So usually you have 2 needs. One is at any point in time, you want to say, okay, this is the recovery plan. So I either can look at it on my screen or print it out. If I have to, share that out with another provider, with the person, it's easy to see that whatever today is the plan. On the other hand, it's kind of a living document, something that's constantly changing. So something may happen in the person's life. There could be a significant life event. somebody may reveal to you after, being in treatment for some time that they're involved with substances. You never knew this before. You need to change the plan. How easy is it to get in and update that plan and still be able to, once you've updated, have that whole point in time plan where I can still get today's plan? And there's different designs for this, but if you're ever looking to test a system, make sure you look at what it takes to update the plan. Often plans focus on the initial plan and not so much on the update. Okay. So I'm going to show you a lot about prompts and pop-ups and things you can sort of build in that can be helpful. And another thing is also to include actually having a prototype plan right in the system that they can call up and reference as they go. Okay. So integrated. So a few ideas on this. So one of the big advantages of an EHR is that it can integrate the different parts of your plan easily. Now, I've already talked about some of the potential pitfalls of that, in that, getting locked into automatic logic that sort of dictates your plan and sort of takes away from its individualization. But there's also other ways, like I said, that you can view things or pull things in that can be helpful. So one of the things, we're not really going to speak to assessments too much here, but you have to think, where is the information from your plan coming from? They're coming from, the information that you glean through assessments. And those are going to be dependent on the questions you ask. So if you're not in your assessing process or in your discussions having that conversation sort of in that format about, okay, what is it you really want here? And what's in the way? And how can we help you get there? You may get to the plan without having sort of gathered the data you need to actually create the plan. And this comes with time, and this comes with practice for both the person in recovery and yourselves. The opportunities to promote patient activation and illness self-management, I'll show you something on that. Being able to pull in references from other documents. So, for example, an advanced directive or crisis management plans, which may be in another part of the record, but you can actually pull in and attach to this plan as part of the whole recovery plan. My experience is the more you can pull things together in one place, the more likely they are to be used. In early days of sort of building recovery plans, they used to have this separate recovery plan outside of the treatment plan that was more peripheral. Maybe one person was working on that. It wasn't the big plan. We're talking about wherever possible you integrate. The last thing I want to mention, I think, is a really exciting sort of new direction and kind of where the field is going. So again, I mentioned in our last session, in our Joint Commission review, we're using an outcome measurement system, which is essentially a client portal system. So prior to the person coming in for their session, they actually complete something either at home on their phones or on a tablet in the waiting room. That's essentially a completion of items from standardized rating scales, as well as items about what their goals are, what they want to focus on, and how they're feeling about the treatment. It's compiled instantly so that by the time they actually walk into the session, it's already there, it's compiled, it's normed, it's graphed. It's a beautiful tool, and talk about being person-centered. It's right literally from the person about how they're seeing themselves at that moment in time. So right now, that system for us is a standalone system, and it's not integrated into the aspects of the electronic health record. And like I said before, we were actually cited, we're talking about all that great work, but you couldn't find it in the recovery plan. So to my knowledge, this hasn't really been built yet, but we're certainly exploring it. It would be really cool if we could take some of that data and actually use it to populate parts of the electronic health plan. So, for example, the data might be part of the the trend line might be part of the data section of a progress note. You just actually put it right in there, and part of the data, so it would save the clinician the time of having to write it. It's current to that particular session. You can see it trended, and then it's integrated right into the note. By the same token, it would be really cool, again, if you're measuring some of these things in a recovery plan, if you have an objective, let's say, that could actually reference this. So someone does a self-rating on their depressive feelings or their sleep disruption, and you actually have a rating of it over time that you could sort of connect that back to the objective to see, how much they were able to progress, and the person was able to see that. Yeah. Okay. So
Janice, I just want to interject. This is Janice. Sorry. Before you move on and show them some samples before we end, I just want to encourage people. We're going to have a couple minutes at the end to take questions. And I've seen a lot of introductions, but no questions coming into the chat box. So we would love to get any questions or comments so we could address those at the end. Sorry, Dan. Go ahead.
Nope, no problem. Okay. So now I'd just like to show you some samples, given everything we talked about, where we sort of came out on some of these items and what they can actually look like in the electronic health record. So it sort of flows in the order that you're going to see it. And I want you to pay attention to a couple things. So, and I'll point out like where we use drop downs versus, full text fields. So number one, you'll see the order that it goes in, and it follows that hierarchy that Janice described. So up at the top, the first thing you're talking about is the goal. And we put the prompt right on the screen so they're looking at it. Statement of the overall goal in the participant's own words, expressing a desired change, improvement, or recovery outcome. Okay? The second piece, and this reflects on the dialogue and the agree to disagree. So we wanted a place, I have found over time, there's a place also where the staff can weigh in when necessary. I would say 90% of the time, you guys, a clinician and the person come to some agreement about what the goal is, on how it's going to be stated, and there's no need to necessarily expound. But there are those occasions when you disagree. And this is a place to capture some of that. So number one, it shows that you weren't ignoring something or just didn't go over it, and that it's reflected in the plan, but it's clearly attributed to the staff and not necessarily as the last word. So you have both views represented in the plan. Okay? We then put within each goal, so again, the things you're going to see is sort of within each goal, what are the strengths, resources, skills, qualities, experience, okay? And how can they be used to help achieve this particular goal? And then we put in the barriers, and we actually decided to separate out sort of the systemic barriers from the personal barriers. Generally, unless prompted, what we found is when you ask for barriers, you would get things like there's no transportation, they don't have money to buy things, kind of those systemic barriers, and we're leaving out the things like, well, the barrier as, to working is they have trouble concentrating. And they really that's what they really need to overcome if they're going to be successful in reaching that goal. So we thought again, to prompt that by actually creating separate spaces within the plan that would ask for those things. Okay. And then we move to the objectives. And again, if you look at the prompt, concrete steps that will be proof that the person is overcoming a mental health or addiction barrier and making progress towards his or her goal. One of the things we're still working on, that we mentioned, and I'll show you the sample of it, is actually to have examples of this and a more detailed description. So we had limits about how much we could put on the screen here, and you want to have limits anyway. You don't want, 3 paragraphs of text of instruction. But, some of the other points in here is, an objective is not, attendance at the intervention. Okay? And then and in that, again, we prompted for certain things. So what's the improvement that you're looking for as evidenced by? And that's the measurable piece of the SMART objective. We figured we would separate that out and specifically prompt for it, because that very often is the area that is missing. And then a target date of completion. Then the objectives would be followed by the services sort of attached to those objectives. And the first 4 fields there, the service type, the provider type, the frequency, duration, those would all be drop downs. You can't really tell it here, but those are things you need specific data. You need it to be in a certain format to support our billing, as the order for services. So we're going to require a person to, pick from those lists. But then the next to it is that service description field. And here's where you get specific. So if this might read, let's say somebody is going to be attending a DBT group. So the service type might be individual therapy, provider type might be the licensed clinical social worker, frequency is once a week for 3 months, but the service description would be something like, Johnny is going to attend a DBT group to work on their, self-injurious behaviors, that should be reflecting back, directly to the objective. And then we wanted to logically link which service the objective, which objective the service was being applied to. Okay. And then just 2 more things. So in that area you just looked at is the services to be provided by your agency. And again, those are the ones that are usually connected to billing, will have specific progress notes attached to them. But we wanted the place to record the contributions either and or of natural supports or other providers. And we are asking for less information here. So we want to know who that is and what the relationship is to the person and what kind of support they're providing. The next box is, so one of the things that happens, again in the golden thread, something important may come up on your assessments. A person has a long history of substance use, but then there's no mention of it on the plan. Now, that may be, of course, you forgot, or it may be a very purposeful thing because the person has basically said, at this point in time, that's not something I really want to work on. This is the place where you would record that. Again, it's really important that it doesn't look like you just forgot, and that you say, look, no, I know this is here. It can be important, but in my discussion with the person about what they want to work on and what they're able to work on right now, that's not something we're going to do at this point in time, but I'm not forgetting. Okay? And the last one is about the personal wellness strategies, or the things a person can do on their own to sort of help achieve their goals. We've been back and forth on this one through the years. And then the last 2 ones, this and the concerns, actually don't sit within the goal hierarchy. They're at the beginning for the whole plan, because what happens here is these can be redundant with the objectives, okay? So if somebody's trying to reduce their self-injurious behaviors and go on a journal or do various strategies, it tended to overlap, but we didn't want to lose it, so we created a place to be able to put that in. Okay, let me just quickly get through because I want to leave some opportunity for discussion. Okay, so again, this is just the more extensive description of what the different elements we think they should contain. And again, for your reference, I recommend that you take the time and take a look at them when you can. This is just a sample of a personalized crisis plan that we actually pull in for reference, so it's readily able to be integrated into the overall recovery plan. This is just a sample of some of the assessment questions we designed. Remember, I mentioned that you have to ask the right questions if you're going to have the information to populate your plan. And again, this is just some samples about how to do that, but you'll see it kind of already builds in, even though you're not in the plan already. It talks about sort of this first question is kind of where you are now, what are your goals, and what's in the way of getting to your goals. And again, some of that staff commentary about that, and then having the conversation about whether it's something you want to work on right now, later, or not at all. And then here's just a piece where we actually built a place for people to build their recovery plan. So the idea is not just identifying the natural supports, but kind of how can they be helpful to you in achieving that plan. Okay, so Janice, I'm going to turn it back over to you to sort of moderate the questions.
Sure.
Thank you, everybody.
Yeah. So far, thanks, Dan. That was great. So far, we only have one question that's come in the chat box, so feel free to go ahead and if you have any thoughts out there that you want to share with us. But a question had come in about what's the relationship of the barriers to medical necessity, are barriers kind of proof of medical necessity? And you can see there, I did respond in the chat box, but I'll just elaborate on that. I mean, the clear descriptive language around the barriers and how they're getting in the way of a person's life, how they're interfering with their attainment of recovery goals, that certainly is an important part of, weaving that golden thread of medical necessity and justifying your level of care and so forth. But I just want to be cautious in saying it's an important part, but it's not the only part, because, medical necessity, really making sure that you're offering the right services at the right time for the right reason has to manifest in other parts of your record. So, for example, you need to be looking at, are you addressing in the plan those areas within the assessment that really did appear to be disruptive, kind of at the conclusion of that assessment. And importantly, if you're not addressing them in the plan, why not? So that goes back to something Dan was just mentioning. They have that field at the end of their format that it specifically says, if there has been some type of a need or a barrier identified in the assessment, if it's not actively being addressed, please note your rationale here. So again, features like that to just make sure you're being thorough and comprehensive and making sure you get that into your documentation. And it's actually a nice feature. You can get your EHR to support that if you build a field in around it. So yeah, the barriers are very important on BG, but they're not the only part. All right, what else do we have here? So client goals get identified over time, and yet there is pressure to develop plans early in care, even when people are not ready to set one of their goals. So how do you make sure the plan does not get ahead of the client? And what's worked for that? So I think the comments that I made early on around goal setting speak directly to this, David, which is that you're absolutely right. goal setting is a developmental process, and it takes place over time. And I think it really requires a degree of a trusting relationship. So, someone comes in highly distressed, maybe they haven't had a great experience in services in the past. They may be telling you nothing on the front end, but depending on what context you're working in, you may have 48 hours to get an initial plan, into the chart. You may have a week. And in those cases, what I would say is that, you really got to back up, and the plans that you're going to be developing as kind of those initial holding plans are going to be much more modest in scope. Their plan is not going to look like Jerry's plan, and there shouldn't be an expectation that they look like Jerry's plan. Developmentally over time, of course, we want to see more, a richer level of goals around that. But I would just say there'd probably be, much more modest goal setting that's happening on that front end, and then it just gets fleshed out over time. We've got some more folks who are weighing in here. And, Dan, jump in if there's other thoughts or ideas.
Yep.
Or for those of you on the line, if you have thoughts and you want to put them in the chat box, that would be great.
This is just one other comment. There are ways, so we're like building a new EHR for us, so we have a lot of opportunities, but there are ways to get in and modify the one you have already. So the things that, generally you can change more easily than others. So you may not be able to change the order that things fall or the hierarchy within the plan, but generally you can change the prompts or sort of the content of drop-downs so they can be more person-centered. So for example, right now, we changed, until we get to our new plan, we changed the prompt on our existing plan about what we're looking for in a goal, because that was something we could get in ourselves without, having to go to the vendor to do. So you may want to look for those opportunities that you can get in for things that you can do yourself.
Yeah, that's a good point. And I think, David, too, the other thing that I would add is that, there are things that we can do with the plan format to remind people around, kind of what are we looking for in that goal statement. But as Dan was saying, really it's the ongoing training and supervision around this that is, is particularly critical. I mean, it is definitely the case. I remember from my, years working on in intake departments and whatnot, sometimes when a person comes in and they're in acute distress, what they really want in that moment is immediate relief from something that's distressing to them, whether it's a clinical experience or a trauma symptom or feeling victimized or what have you. So in those cases, very early on in those initial plans, you are focused on that immediate relief, right, which is often targeting those direct clinical symptoms, right? So you heard Dan and I talk throughout the presentation about, the goal should be the life role, the going back to work, visiting my kids, having some hobbies. And while that's true, the point that David is raising is important, is that this is a developmental process over time. We start where people are at, and in that moment when they first walk in, what do they need? The problem is that 6 months or 6 years later, if the plan is still focused narrowly on the clinical symptoms, that's where we want to start sort of moving beyond the management of that and thinking about what does that kind of broader life role goal look like. So Robert's just asking a question. Let me end with a couple of housekeeping things. Because we do give a lot of information. Some of these, Robert, we're trying to cover a lot of territory. There's a lot to absorb. So is there a way to download and print some of the information? So Robert, if you go up into the comments, and for everyone, Ingrid did, for ease of accessibility, put the website of the MHTTC where the webinar slides are going to be posted. So then you can look at them at your leisure. You can download them. And that type of thing, and you can have them for your use and reference. And just a reminder that I will also make sure that I post those couple of tip sheets, the recovery plan documentation, kind of quality indicators checklist as well within those documents. Have we found it helpful to have clients keep track of meeting their short-term goals weekly, such as hygiene goals? I mean, what I would say, I like to actively use the plan. And so I don't want the plan to be something that gets put in the chart and it gets dusted off 3 months later, and then we kind of revisit it. I think anytime you can, if you're seeing somebody weekly, and if they have an objective in your plan, and you can pull it out and you can say, hey, this is where we had hoped that you would be by this point in time. Have you gotten there or not, right? And if not, what is it that we need to do differently together to give you a better shot of getting there? So yeah, I would say it's important in general to have people, together reflecting on their progress, because then if you're not attaining the objective, that doesn't mean it's a failure. It means you got to put your heads together and figure out, maybe you got to be thinking about additional services and so forth. So yeah, I think definitely it's a good idea to be using that plan actively.
I would add,
so
again,
go ahead, Dan.
Just quickly, again, these new portal systems are actually, that's part of what they're moving towards, to make it things more live and more dynamic, so you're actually reflecting on them on a more regular basis. So I think things are moving in that direction.
Yeah. Okay. Let me just end by saying a housekeeping item here. After the webinar, again, please visit the MHTTC site to be able to download slides. D is making a comment, you're having a hard time with the link. I think I would just Google the MHTTC site. I think it should get you there. They had been posted previously and working out okay. And if not, shoot us an email, and we'll make sure you get access to those. But they will be posted on the site. You're also going to be getting an email that has sort of a post-webinar series knowledge check, and it is a required part that you actually complete the evaluation and the knowledge check in order to be eligible for your CEUs. So we just wanted to remind you all that will be coming to you. So thank you very much for joining us. For any of our New England representatives who are on the line, if you're excited about this stuff, if you want to learn some more and work together with a committed group of individuals in a learning collaborative, stay tuned for more information in the coming months, because there will be an application being put out from the MHTTC around that topic and opportunity. So Dan and I both would love the opportunity to work more intensively with some of you all and support your efforts on this. So with
Likewise.
that,
Thank you all.
We're going to go ahead and sign off here, just in the interest of being respectful of folks' time. And again, feel free to send questions off to the MHTTC, and they'll definitely redirect those to Dan and I, and we'd be happy to try to answer them. So good afternoon to everyone, and enjoy the rest of your day.